Now let's look at our 5-point scoring system that we use for reading, but in truth, it's really a 4-point system because nobody uses spectroscopy for reading, imaging, scoring. And in fact, many people, including our colleagues in Germany, don't even use dynamic contrast enhanced MRI for screening of the prostate and have found no difference between the diagnostic study with DCE MRI, dynamic contrast enhanced MRI, and the screening study that excludes it. So if you are doing a screen, who might be a candidate for a screen that hasn't had a biopsy? Because that's a question that's often asked. The virgin prostate. Somebody with BPH, and maybe the prostate is gradually, slowly getting bigger, and the PSA is low, 4, 5, certainly under 10, and it's rising very slowly. The patient isn't that symptomatic otherwise, and the patient has no strong family history of carcinoma in the prostate or in other organs like the colon and the pancreas. That would be a candidate for somebody that has not had a biopsy to have a screening MRI looking for areas of diffusion restriction, especially in the peripheral zone, and morphologic abnormalities on the T2 weighted image. So here is our T2 weighted image, performed with the cardiac external coil. It is not endorectal, so there's been nothing placed in this patient's butt. The buttocks is collapsed because they've had the proper prep. Tune into the vignette on prep if you need to. It's fast. It's inexpensive. The patients like it a lot better when you don't have to put anything in their rear end. So this is the way to do both screening and diagnostic MRI. Now I've got some of the parameters listed on the left. I'm not going to read them off to you. You can see the scan time. You can read them for yourselves. And this is an axial series of images. Look at the overall slice thickness. This is a 3.5 millimeter slice thickness, so this is done with 2D technique, but exquisite detail showing you the peripheral prostate capsule. We'll talk about the anatomy separately, but I'm just showing it now for protocol assessment. And you would go up and down looking for what? Looking for areas of mass-like, confluent, or round hypointensity in the peripheral zone. What would you be looking for in the central zone on the T2 weighted MR? Something akin to wax on, wax off, something lentiform, something that looks like you took a piece of charcoal and started erasing the central and transitional zones, whose anatomy will be defined shortly. So don't worry. We're on to anatomy in a little bit. Let's keep going on to the next portion of the examination. This is a T1 weighted image. This actually doesn't come into the scoring system. However, you'll have a T1 weighted image for a few reasons. One, it's awfully nice to look at the periprostatic fat and see that it is clean. It's also an excellent way to depict bony metastases. It's also an excellent way to look for lymphadenopathy. The clean fat around the posterolateral corners at 7 o'clock and 5 o'clock with these small, tiny little dots at 7 o'clock and 5 o'clock helps you clear the neurovascular bundle. So if you lose that circumferential fatty ring, then you have to worry, if you have a mass in the prostate, about neurovascular bundle invasion. So here is a coronal. Now, not every scan needs to have a coronal projection. In fact, if you're doing the study three-dimensionally, you can reconstruct the coronal projection. So this is an optional one to add to your screen, to your diagnostic study. You're probably going to have a coronal for lesion localization, but not necessarily for the screen itself. And in the coronal projection, parameters shown on the left are abnormality on the T2, which looked a little rectangular. I'll go back to it for a minute. Looks a little rectangular. It looks a lot more round in the coronal projection. And we're going to divide up the prostate into a base, a mid, and an apex, and that'll be a story for an anatomic day. But at the base, on the viewer's left, the patient's right, there is a round mass in the PZ or peripheral zone of the prostate where most of the cancers occur. Here's your hyperintense PZ with a tumor growing straight out the top. So in this case, the coronal projection helps you localize the position of the tumor, although if you're pretty advanced, you wouldn't need to do that in the axial projection. You'd figure it out by looking at the axials from top to bottom, and you would know where you are anatomically. If you want, you could also include a sagittal T2 weighted image for further localization, although for screening, that wouldn't be necessary. And again, if you have three-dimensional imaging, you can reconstruct your sagittal. You don't have to acquire it, and that gives you extreme efficiency in performing the exam. Then we've got diffusion-weighted imaging. This is the second most important, if not equally important, as part of the examination. So what we'll do is we'll get a baseline study, B0, in which the diffusion gradients are turned off. So it's basically a very, very fast echoplanar type T2 weighted image. And then we start turning up the dial. We turn up the heat. That's what elevating the B value does. It makes the gradients tighter, higher. It shows with greater sensitivity diffusion restriction. And as we go from, say, 0 to 400 to 800 to 1200 to 1600, an area that diffusion restricts gets brighter and brighter and brighter, as opposed to, say, an area that has high T2, like this one, gets darker as you dial up the B value. Now, this is only a B700, but we like to go to a B value of at least 1400 and preferably 1600. What's the least B value that I will work with? 1200. 1200 works on most scanners. 1400, very acceptable. 1600, ideal. So this area right here, which didn't look like much of anything, oh, it's diffusion restricting and has a lentiform or oval shape to it. These two stools of the prostate MRI, the T2 spin echo, fast spin echo, 2D or 3D, and the diffusion weighted image are the guts of the prostate exam. You'll then take this information and you will convert it, as we'll see in a few moments, into a parametric map, a so-called ADC map. And the bright area that you saw in the left gland, your right, will now appear dark. And we'll explain to you why that is in a moment. Another component of the MRI, less important than the ones you've already seen, less important than the T2, the diffusion, and the yet-to-be-shown ADC map, is the DCE MRI, the dynamic contrast enhanced MRI. Its main value is in helping you further determine how aggressive a lesion is. If you see an area that immediately enhances in the first 7 seconds after contrast administration, on the very first arrival of the contrast into the adjacent vessels nearby, odds are you've got Gleason 8, 9, or 10. And especially if this intensity starts to smear like cream cheese on a bagel, that means that it's washing out. And that's another negative, ominous sign that you're dealing with a Gleason 8, 9, or 10. Other signs that you're dealing with a high-grade Gleason lesion are size, bulkiness, extreme diffusion restriction, very low signal on the ADC map, broad areas of abutment of the capsule, all signs of something that is more aggressive. So here we've got a combination of the dynamic contrast enhanced MRI in a different patient and a T2 weighted image in a different patient, this a cancer, this an aggressive cancer. So we're showing you two aspects of the exam. Now here's something else that you can do as an option, and that is the three-dimensional T1 weighted image. I don't routinely perform this, but if you're looking for very small nodes or you really want to drill into the neurovascular bundle and you're not sure if you see the bundle around the edges at 5 and 7 o'clock around the prostate, you may opt for 1 millimeter axial slices using some form of T1 appearing GRE. I don't do this routinely. You can also reformat or reconstruct it. Now let me show you the ADC map, which is the second most important part of the examination, or perhaps even the most important part, and it's derived from the diffusion-weighted sequences. So diffusion and ADC map for you beginners go hand in hand. Diffusion makes the map. So what is the map? The map is a pixel by pixel blow. In other words, a blow by blow description, that's hard to say, of the velocity of flow in each single pixel on the image. So if you have diffusion restriction, what's the velocity? Lower, right? Because it's not moving. It's restricted. So the lower the velocity, the lower the intensity on the ADC map. So what's bright on diffusion, dark on the map. So that's how you do it. So you've got a mass on the T2 weighted image in the peripheral zone. You've got diffusion restriction that's bright on the diffusion image. You've got low signal intensity on the parametric ADC map. And if you choose to do dynamic contrast enhanced MRI and the lesion is aggressive, it will enhance early and therefore be bright on this color flow map of dynamic contrast enhanced MRI. So that's the exam. Notice I did not show you a spectroscopy. I also said that the DCE MRI does not have to be performed in every single individual. It's going to be elective and selected by you based on judgment and the scenario, but you must have the T2, the diffusion, and the ADC parametric map.